So welcome. So I'll be on time. So I think few people have joined. So let's start. So I am Dr. Koushik Tripathy. I am a practicing consultant, Retina and Uvea specialist in ASGI Hospital, Kolkata. So I am thankful to Muthuswamy sir, Vijaya ma'am, Gada ma'am, and other faculty members and the members of MVUPGO. And I thank Dr. Shobhik Datta, who is a fellow of Emulsification and Medical Retina in ASGI Hospital, BT Road, Kolkata. And I am also grateful to Dr. Ramnath Gute sir for his enlightening philosophy. So basically, we'll give 3 to 4 minutes for each candidate. If you are not answering, please do not prompt and please mute. So try to learn and try to take good things from the discussion, like a swan does in Indian philosophy. It is believed that swan can take milk from a mixture of milk and water, and also try to look at what is presented, not what is absent. Also, when you are presenting or reporting a case, focus on what is there and be a half glass so that you can fill the glass with more water. If you think that you know everything, then there is no chance of learning new things. So as I said, if possible, when you are presenting, you turn on your video camera, because the like attitude or your body language are also important. It is a mock exam. There is no need to worry or like hurry. So basically, in these exams, the examiner has to find a way to give you marks. So think, then speak. Do not hurry. If you do not know, say that I do not know. Examiner wants to know what you will do and not what is written in the book. So, and obviously, you must not miss some disease which is vision threatening or life threatening, like giant cell arteritis or central retinal artery occlusion. So, do not say I'll refer to a like other specialty colleague. Try to say that I'll coordinate with the like retina specialist or the oculoplasty specialist in managing this case, and my plan of management will be this. Definitely practice history taking, evaluation, and all the exams in all of your patients of all subspecialties. Do not just focus on your own subspecialty, and also try to focus more on the things which you do not know, or the specialties which you are weak. So that will help you in strengthening your weaknesses, and and will help you in the exam. So if you have any questions, you can add. So who will volunteer first?
I will transfer.
Dr. Mean. Okay. Please, like, if possible, you can switch on your video, and if it is not possible, it is okay. Please introduce yourself, Dr. Meenu.
So I'm Dr. Meenu Anthony. I'm a general ophthalmologist, and I'm from Kerala.
Okay. So this is a photo. This is a like 30-year-old driver who has come to you. He's saying that he has some floaters in the uh, left eye. So this is the finding. What do you see, and what do you think is happening here?
Okay. So this is a fundus photograph um, of the left eye. Here the media is hazy. This appears normal. Vessels are a mild tortuosity. Veins are dilated. AV ratio, and there are multiple areas of yellowish white chorioretinal lesions with overlying hemorrhages in the supratemporal as well as in the infratemporal quadrant. There is vitritis also. Um, this is macular details are not clearly visible. This is suggestive of posterior uveitis.
Okay.
Um,
What kind of uveitis is it? Is it retinitis or choroiditis or something else?
that choroiditis.
Now, how do you differentiate choroiditis from retinitis?
Um, I don't know, sir.
Okay. So I am saying that this is a retinitis and there are hemorrhages in the posterior pole. So what would be the differentials here?
So it could be infective causes like tuberculosis, then syphilitic lesions, then vasculitic causes, Behçet's disease, sarcoidosis.
Are the infective causes over with TB and like syphilis? What are the other retinite causes of retinitis?
Um,
I think 4 minutes are
CMV
over. So,
retinitis, CMV
yes,
retinitis in HIV,
okay. HIV, like herpes simplex virus,
toxoplasmosis,
zoster plasma. These are important things which you must, and you will write a note on the, about how. Yes, Dr. Temina.
Sorry, sir, I forgot to mute myself. Sorry.
Okay, okay.
Good evening.
So basically, you need to know what are the differences between choroiditis and retinitis. You will read, or let me tell you, retinitis is because it is in the retina, so retina will become white. So, but subretinal things will not be visible. So, in retinitis, choroid is not visible. That means choroidal vasculature is not visible, and it is a white lesion. Sometimes because it is in the retina, retinal blood vessels can be affected, and there can be hemorrhage. So in choroiditis, the lesion is subretinal. That means retina is visible clearly and the choroid is involved. The color is usually yellowish or greenish in active choroiditis. So basically location of the lesion is important in the focal retinitis may also look like cotton wool spots. So here the images are like they are whitish lesions in the retina. This is in the retina, not subretinal. Because subretinal things will have overlying retinal vessels which will be not involved. So this is a retinal whitening which is due to retinitis. And this case has CMB retinitis. Vitritis, inferiorly there might be there, but the typical posterior pole involvement with of retinitis and hemorrhages, they are suggestive of CMB retinitis. I think we'll go to the next candidate. Anyone please volunteer. So please, Doctor, for Dr. Minu, you need to read
yes, sir.
like causes of retinitis. How do you differentiate retinitis from choroiditis? And
Yes,
also how do you manage those cases? Read about those.
yes.
So
So,
if we're confused in the exam, we can say like it's chorioretinitis, retinochoroiditis if we're
Yes,
confused.
yes, you can tell retinochoroiditis or chorioretinitis, but the examiner might ask you, what do you think is the most prominent? Like, is it more of retinitis or more of choroiditis? Then you need to like know, just see the images. This is a retinitis. I'll show the choroiditis images also. So this is retinitis, like whitish retinal lesions which are suggestive of, because retina is a clear structure, transparent structure. When it gets infected or there is ischemia, it becomes white. So that, and as you can see that the location is retinal. So this is retinitis. Choroiditis is subretinal thing.
Sir, I have a doubt, sir.
Hmm.
This is Abhinaya. Sir, this is retinitis, but we can see the blood vessels clearly, no, sir. In some whitish
Yes,
lesion above that, we can see the blood vessels clearly, no, sir.
yes. But
So,
the details of choroid is not visible. So
okay,
this
sir.
basically you need to see like few cases with retinitis. Just search retinitis or
Okay, sir.
CMV retinitis in the Google and see, and search choroiditis or Like choroidal lesions will be like retina will be clear. It will be totally subretinal thing.
Okay, sir. Okay, sir. Okay.
Just see the images.
Okay, sir. Thank
Uh, who will volunteer next?
Will volunteer, sir. Good evening. I'm Dr. Rashmi.
Dr. Rasmi. Dr.
Yes.
Rasmi, please introduce yourself. Just
I'm Dr. Rashmi. I'm a general ophthalmologist. I'm working in Muscat. Yes. So
Rasmi.
this is a fundus photograph of the left eye, showing the disc. The disc is normal, normal cup, and the neuroretinal rim appears normal. And then there is a large whitish, what is it? Something. It is a whitish structure that is present probably in the vitreous.
Okay, this patient gives a history of an injection in the
Yes.
eye.
So it would be intravitreal triamcinolone acetonide. Ozurdex, sorry, Ozurdex injection, which is Ozurdex implant, which is in the eye.
Like, why is it not triamcinolone?
Triamcinolone is it will spread. It is not implant. It is a solution which is
It
given
will be
and it
like
is
patchy
given.
areas of multiple areas. Like it will be like vitreous hemorrhage or something. It will be diffuse
Yes, it
or
will be whitish particles. Yes, in the
a
inside.
long like implant. So
Yes.
what is the composition of Ozurdex implant?
Ozurdex is containing dexamethasone. Um, the concentration is uh, zero point 0.7 micrograms. I'm not sure.
0.7 microgram. Okay, just 0.7 milligram. So what are the
Milligram. Okay.
indications of Ozurdex implant?
Ozurdex implant indications, we can give them in diabetic macular edema, which is not responding to anti-VEGF injections. For vein macular edema from vascular occlusions, vein occlusions, um, and for um, mainly for macular edema from these two conditions. Mm.
Any other condition? Because it is steroid. Steroid is used. Steroid can be
Inflammatory vasculitis, like which is non-infective vasculitis, like sarcoidosis, or um, even Behçet's intravitreal steroids can be given.
intermediate uveitis with cystoid macular edema or even pseudophakic
Yes.
cystoid macular edema can be treated with this.
Pseudophakic cystoid macular edema is an indication. Yes.
What are the possible side effects?
The side effects that the patient can have development of cataract, increased intraocular pressure mainly. So these two are the main side effects. And
Yes,
glaucomatous changes in the optic nerve. Yeah.
excellent. Dr. Rasmi, very good.
Yes.
Very nice.
Yes.
We'll go to the
Thank
next.
you.
So, mhm.
Thank you.
Who will volunteer next?
Good evening, sir. Hello.
Dr. Aparna, please introduce Dr. Aparna.
I'm Dr. Aparna Darswan, general ophthalmologist. I work in Faridabad
Okay.
daily.
So please discuss what is seen here.
This is a fluorescein angiogram of left eye. It's a late venous phase. The disc is stained, hyperfluorescent. I can see the vessels it's a late phase, so the vessels hyperfluorescence is fading. And at the macula, I can see multiple areas of leakage.
So what is the pattern of this leakage? What is this called?
It's looking like a pataloid pattern, cystic spaces in the retina, most likely a cystoid macular edema.
Okay. What could be the reason for this such a finding?
The cystoid macular edema can be seen after surgeries like cataract surgery, glaucoma surgery, retina surgeries, and it is also seen in inflammations like
Like
posterior uveitis or even intermediate uveitis.
Okay.
And it can be seen in certain retinal dystrophies like retinitis pigmentosa.
Okay. Okay.
Um,
If it is retinitis pigmentosa, we do see such kind of
yeah, so it will not
like
show leakage on FA. The
what are the conditions in which there is cystoid macular edema on OCT, but the fluorescein angiogram doesn't show petaloid leak.
so in RP,
Okay. Just tell full form, not RP, retinitis pigmentosa.
retinitis pigmentosa,
And
and so I can't recall. I read it, but
okay, read about this. So this patient, I say this is a patient after cataract surgery, 2 months after cataract surgery, and he has reduced vision. So what are the like management options in such a case?
so we can start with topical non-steroidal anti-inflammatory drugs because it responds to
Like
non-steroidal anti-inflammatory drugs,
like
and if it does not respond,
like what
ketorolac, napafenib, or
what is
bromifenib.
the what is the dose of nepafinac?
So we give it a 1 drop 3 times a day, and bromifenib is given one
What is
drop
the
2 times a day.
percentage of nepafinac?
So it is 1%.
Read about this. And yes, he did not respond to nepafinac. Then what is the next step?
So next we can give topical steroids. And if
Okay.
it doesn't respond to topical steroids, then we can give a posterior subtenon periocular steroids or intraocular steroids, intravitreal steroids.
Intravitreal, what are the intravitreal steroids you know of?
So we can give triamcinolone acetonide, dexamethasone, and fluocinolone acetate.
What is the dose of intravitreal transfusion?
So it is 4 milligrams, but nowadays even lower doses are being tried at 1 milligram to reduce the side effects. And
Okay.
dexamethasone, like it is 700 micrograms, and fluocinolone acetate is 190 micrograms.
Okay. So what are the other considerations on like uh what management option would you start? Like would you start with like topical nepafinac with every case, or you can start with a more aggressive approach initially
It will
also?
also depend on the visual deterioration of the
Hmm.
patient. If the vision is severely affected, then I will start with periocular or intraocular steroids.
Other
In
than
milder
visual,
cases, we can try topical NSAIDs first.
other than vision, is there any other thing which will guide your management option?
So if the patient has had a complicated surgery, then chances of just relieving with topical NSAIDs would be less. If patient has had a vitreous loss, or there are other things we have to look for, whether there is a vitreous wick or there is vitreous in AC or any kind of extraction on the vitreous. So that
If there
those
is
need to be taken care of.
if there is vitreous weak, how would it change your management option?
So we can try a vitrectomy, clear the vitreous from the anterior chamber so that the pull on the vitreous is relieved.
Yes, but other than vitrectomy, are there any other options?
So we can try with Nd:YAG laser.
Yes. So yes, I think you did good. So these are the options, and also CE at the OCT central macular thickness. That is a
Yes.
major
Right. Yes, sir.
factor which is like an influence your decision. If it is very thick, like 500, 600 micron, then it might not respond. So very nice. I think we'll go to the next candidate
Thank you, sir.
who will.
Sir,
Mm,
in this condition, we need to inject anti-VEGF or no rule for anti-VEGF in Evangelist.
Basically, anti-VEGF can be used, but because it is mostly inflammatory condition, so we'll try steroid first. So there are certain cases in which there is advanced glaucoma or cases who have high steroid response. So in these cases, if you cannot use steroid, you can try anti-VEGF. So, but do not tell anti-VEGF as the first treatment option because you need to give steroids here. So if steroids are contraindicated or are not available or something, then you can give anti-VEGF as an option, but it is not a primary like first line choice. So who will take the next for next image?
May I, sir? Dr. Nayana.
Dr. Nana, please introduce Dr. Nana. So this is a
Sir, I'm Dr. Nayana Sebastian from Kerala. I work as a general ophthalmologist.
so please describe what you see. So this patient is complaining of floaters.
Okay. This is a color fundus photograph of right eye. Media appears hazy. Disc margins not well defined. Vessels seen appears normal. There are multiple areas of pigmentation and whitish fluffy areas overlying the pigmentation scattered one area inferior 0.5 disc diameter inferior to the disc, and then another large area along the temporal vascular arcade, and there are um, infiltrations in the peripapillary area also, whitish area in the peripapillary area.
So what could be the happening here? What would be your provisional diagnosis here?
So this could be a case of recurrent posterior uveitis, a second, more like not the first attack, which is suggested by previous attack suggested by pigmentation, a new attack by the in exudation.
What could be the cause of posterior uveitis? What is the most common cause of infective posterior uveitis?
Toxoplasmosis.
Suppose I say this is toxoplasmosis. So how would you treat? And when would you treat?
When would you treat? Okay. Toxoplasmosis treatment is indicated when it is the only seeing eye, when the lesion is threatening the papillomacular bundle, when the lesion is near the disc or any major vessel is near the disc or any major major vessel.
So what would be an indication to treat this patient?
In this, the lesion is near the disc, sir.
Also, if the vision is reduced, like if there is very severe floaters, if patient is complaining that yes, I have severe floaters, then also you can treat. What would you how would you treat?
First, I would ask the patient if it's a lady, at the childbearing age, I'll rule out pregnancy. Then I would start the patient on triple drug therapy, sulfadiazine 400 mg initially, then trimethoprim and prednisolone after 24 hours, 1 mg per kg. And if the patient is not responding, I would add clindamycin also along with it.
Any other drug which you can use?
Azithromycin can also be used.
Cotrimoxazole you can also use.
Okay.
So how do you know that it is working, the drug?
There will be reduction in the vitreous haze and the lesions will start to shrink with less exudation.
Not exudation, there is no exudation now, but the whiteness will reduce and it will be more pigment, will become sharper. So, and also most of the people will not start steroid after 24 hours. Most of the people will wait for 48 to 72 hours after the starting this cotrimazole or this sulfur drugs. So what is the if I give posterior subtenon or if I start the patient on oral steroid alone, what is the problem? Is there any problem or it is okay?
There will be severe worsening of the inflammation, sir.
Yes. And how do you confirm this case, like whether this is and how do you like evaluate such a case?
I would check the vision, the color vision, and look for RIPD. Then I would evaluate the other eye also to see if there any evidence of congenital toxoplasmosis, and then I would check the IOP. Then I would do a detailed slit lamp examination and a dilated posterior fundus examination. And then I would send the patients. I would evaluate the patient for all the common uveitic entities. I would send investigations for like complete blood count, urine routine, then toxo IgG, IgM, Manto skin test, and VDRL, and serum ACE levels also.
Thank you. I think you did very nice. So we'll take next candidate who will volunteer next. Anyone? This is just a mock.
Good evening, sir. Dr. Tanmay here.
Dr. Tanmay, please introduce yourself.
So I'm Dr. Tanmay. I'm a general ophthalmologist. I'm working in Ambala, sir.
Okay. So this basically this photo was the posterior pole of this patient, the previous patient. So this old scars are due to old toxoplasma scars. So this is Dr. Tanmay. What do you see?
Sir, this is a fundus photograph of a patient. It is showing the peripheral part of the fundus, and there are perivascular seething, and there is inflammation in the vitreous, which is not severe, and because of the inflammation, there is slight haze obscuring very fine capillaries, but uh, secondary vessels are visible with the perivascular cuffing and exudations.
Basically, media is not very hazy because you can see the vessels and also choroidal vessels are prominent. So, what is your diagnosis here from the findings?
Sir, this could be a case of intermediate uveitis, or it could be
No.
sarcoid
What is the preliminary finding here? What is like if there is seething around the vessel? What is it called?
vasculitis.
Okay, retinal vasculitis.
Yes, sir.
So, what are the causes of retinal vasculitis, which involves vein predominantly?
Involving venous structures, examples are like sarcoidosis and tuberculosis, syphilis, and
Syphilis. What does syphilis involve? Like just read up. You will post a like chart on the like specific vessels which are involved in a specific disease.
yes, sir, yes.
Okay.
Sir.
This patient doesn't have anything, but how can this patient have poor vision? So what would be the reason of poor vision in such a case?
Cystoid macular edema can be cause of poor vision,
Okay.
and other causes could be if there is any vitreous hemorrhage because of vasculitis.
How would vitreous hemorrhage happen here?
Vitreous hemorrhage because of vasculitis could be because of traction in the blood vessels, or because of retinal tear.
What is the common cause of vitreous hemorrhage in case of retinal vasculitis? How does it happen? What are the stages of retinal vasculitis?
So, stages, I am not sure regarding
So
this.
there is inflammation.
Yes,
Okay.
sir.
This is inflammation stage. Then there will be ischemia. The vessels which are inflamed, they will be blocked and there will be a localized retinal venous occlusion or arterial occlusion. Mostly these are involving vein. The retinal peripheral vascular venous occlusion will happen and they will cause new vessels later. So inflammation, then ischemia, then new vessels. So new vessels. So you said tear. Tear can be a cause, but it is a rare cause in of vitreous hemorrhage in vasculitis. In vasculitis, most likely there will be new vessels, peripheral new vessels, which will bleed.
Sir.
Just like speak of the most common findings or common causes.
Yes, sir.
And also there can be traction that can also be there, but the cause of vitreous hemorrhage is primarily new vessels. So
Yes.
how would you treat? How would you manage this case?
For management, I'll look for any systemic causes if it is bilateral involvement, and in most cases it is bilateral. So we'll send for blood investigations, and complete blood count, along with screening for all the infective causes and inflammatory causes, ESR, CRP, and uh, screening for tuberculosis and sarcoid investigations for sarcoid, like chest X-ray and CT scan, and then on depending on the case and depending on the initial investigation findings, then we can do further investigations for depending on the case.
Okay, thank you, Dr. Tharman. You did very good. Just read about the like you'll post a chart, like there is a American Academy of Ophthalmology UVAT's book has a chart. You post it on
Yes.
this, and also read about the management options in such a case and what are the indications for management. You may not, if there is a peripheral vasculitis not involving vision or anything, it is if it is just a peripheral finding, you may choose to observe also.
Yes,
Sir,
sir.
I have question. Can I ask? This
Yes.
whitish lesion, it is little similar to this tubercle, small tubercles in the retina also, and in the
Tubercle.
choroiditis, the small
Yes,
tubercle.
tubercle can be a differential here, but tubercles are typically choroidal. So the retinal look at this, the vessel is involved because the vascular there is narrowing near the whitish area. So in tubercle, if it is only tubercle without associated vasculitis, the vessel will be normal. So it will not have
And
any narrowing which is seen here. And the choroid,
and
it will be choroid, subretinal lesion. So this is in this photo, you will have to tell that it is a perivascular sheathing because vessel is definitely involved and vessel is narrow there where the whiteness is there.
Excuse me, sir. Sir,
Yes,
could this be segmental periphlebitis in sarcoidosis?
yes. That basically this is periphlebitis. Veins are involved. So there will be multiple differentials, including sarcoidosis. In sarcoidosis, what is the sign seen?
Uh,
Typical
Wax dropping, but sir,
Candle
it
wax.
is not
Candle
candle
wax dripping.
and dripping. Basically, a specific area, long area of segment. This is a small area, small segment which is involved, but in sarcoid, the segment is usually little longer, and they will the exudation or the seething will involve in the nearby areas also. Some will post like the Takis de boogie appearance in the group also. So I'll take the next
Doctor,
candidate. Yes,
Doctor,
Dr. Heva.
hypertension, choroidopathy, and malignant choroidopathy, it is not differential diagnosis, right? This Seger's
No,
Elton spot and
no, in this case, it will not be a differential diagnosis because those findings are typically choroidal findings. So this is the retinal vessel is involved here. So that is one important. So, so that no, that will not come. Yes, Dr. Heva. So, who will like volunteer next? Anyone?
okay, sir, I will take Yasmin,
Okay. Hmm.
general ophthalmologist in Cairo. Then this is fundus photo of
Yes,
the
please just introduce yourself and then start.
uh, Dr. Yasmin, general ophthalmologist from Cairo, Egypt. Then this is
Okay.
fundus photo. I think of the right eye, because the posterior arcade is not typical here. Blood vessel, choroidal blood vessels is more evident, and the disc looks like hypoplasia disc, and I can see the macular fovea reflex. So I think this is the. What about the other eye, doctor? Same.
Similar, yes.
So
Then
my
what would be?
differential diagnosis is albinism.
Okay. So if it is albinism, so what are the causes of poor vision?
Disc hypoplasia, optic nerve hypoplasia, and foveal hypoplasia.
Okay, and also refractive error. So how do you define optic nerve hypoplasia?
I can't recall it, sir.
Okay, just read about it. And how do you know that there is foveal hypoplasia?
By OCT.
By clinically, how do you know?
It
Basically,
will be small.
yes, foveal avascular zone will be small or non-existent. There is usually in fundus there is an area where retinal vessels do not go, so that is the area where there is fovea. But in albinism there will be like the foveal depression will also be absent, and the uh, macular, the presumed foveal area will have retinal vessels going through. So that is, and also you can do angiogram to see that foveal avascular zone is non-existent or very low, and you can do what will the finding in OCT, Dr. Yasmin? You said OCT. What will be what will you see in OCT?
The foveal bit is not similar to the normal, like there is no bit.
So what is it called? There is no what?
Uh, no foveal bit, like not preserved foveal bit or not typical foveal bit.
No foveal pit. So what will be there? What is that called in OCT finding?
Closed foveal bit.
That is called fovea plana. Basically, when you do scan OCT, you will not be able to find the depression. So the fovea will be like flat. So that is called
Yes,
fovea plana. So yes, you will
fovea plana.
read about the fovea plana, and also there is, I think there is a grading of foveal hyperplasia. Read about it. You did good.
Okay.
And also read about
Thank
like albinism and its system association, like Hermansky Podolak, and what specifically is seen there, and also what are the like changes in the chiasma, optic chiasma. So I'll go to the next candidate. Who will volunteer now?
Sir, I'll volunteer. I'm Dr. Monica.
Yes, Dr. Monica, please
Uh,
introduce yourself.
sir, I'm Dr. Monica, cornea and phaco surgeon, sir. I'm from Bangalore.
So please discuss this.
So, this is a colored fundus photograph of the. Sir, I can't make out.
Why it is visible? Which eye?
Okay, this is a colored fundus photograph of the right eye.
What is this? Can you
Oh,
see my cursor?
yeah. Sorry, sir. That's Michael. I can see of the left eye. Showing the disc media is clear, disc is within normal limits, but there is a mild blurring of the inferior margin. Vessels, there is mild tortuosity. Inferiorly, I can see a whitish excavation with clear borders, most probably
So,
suggestive of the coloboma.
mm. So what are the risks in such a case? What are the retinal risks in such a case?
There will be a chance of neovascularization.
Why neovascularization?
Mm,
Is choroidal coloboma associated with, can be associated with neovascular? Which kind of neovascularization will be associated with choroidal coloboma? So what is the typical association of choroidal coloboma? Like what can happen? How can this patient lose vision? Okay. How does this choroidal coloboma form? Why did it form here?
there is an absence of fetal fissures during the development.
Absence of fetal fissure. What is the term? Like the embryonic fissure did not close.
Yes, sir.
Absence of and also there is a high chance of retinal detachment, not neovascularization. Choroidal neovascularization can happen in the margin of the choroidal coloboma, but that is a rare
Okay.
thing. Primarily, there is a high risk of retinal detachment in such a case.
Okay.
So, what are associations of this? What other disease can be associated with this choroidal coloboma?
Systemically, it may be associated with CHARD syndrome,
Okay, what is
and
the syndrome?
there will be cardiac abnormalities, renal atresia, renal abnormalities.
And just read about it. I think you did good. And also,
Thank you, sir.
is there any prophylactic management treatment to this? Can we have anything which can prevent retinal detachment in such a case?
No, sir, I don't have the idea.
Please read about it because coloboma can be given in under here. So prophylactic laser barrage of the fundal coloboma has been described, but
Prophylactic. Okay, sir.
not everybody
Third type
practices.
of third, third type of RD here is oxidative RD or could be rheumatogenic.
What?
Type of RD here, it could be
Rheumatic.
oxidative or
No,
rheumatogenic also.
no. It is dermatologist. It is not exudative.
Okay.
Exudative RDs are due to something which is leaking or which is exuding fluid. There is usually a break in the margin of the coloboma or within the coloboma. So that causes the retinal detachment and it is dermatogenous in nature. So we'll take the next question. Anyone, please volunteer. New candidate will be preferred. Yes. Who?
Yeah. No, not you, yes, me.
Uh, is there any other candidate? There are so many people who are there. Please volunteer. This is there. It is a mock exam. This is I am not an examiner. This is just a like we're trying to find out what questions can be asked and how prepared you are for your exam. So that's what we are doing. So do not like Dr. Hala.
Okay, I will try.
Yes. So this
Uh,
I am saying like what the clinical features. This is a hyperopic patient, and you are seeing that there is a like a round-like structure infratemporally visible in both eyes. So patient is 60-year-old. So what is this? The inferior-temporal inferior, there is this
the temporal color photograph of I cannot determine the eye
right eye.
showing attenuated vessels and the dome-shaped shadow in the inferior of the down part of the photo, and there is maybe this is the fovea up. If
No,
this
no.
is this is
This
not the
is the
fovea.
this is the fovea. Can you
Yeah,
see
yeah,
my A? So this is the fovea. This is right eye. There is infratemporally. There is this thing, and this is
yeah.
retina
This,
like thing.
this is detachment.
Okay. And what could be the other differentials?
What could be what the other differentials? It could be tumor mass,
So no,
choroidal
no,
mass.
there is no tumor. It is like a transparent thing. It is like a transparent thing infratemporally in a hyperopic old patient. This
Retinoschisis.
okay. Basically, there will be two differentials: retinoschisis or retinal detachment. So how do you differentiate retinoschisis from retinal detachment?
Um, Actually, I don't want to tell mistakes, but maybe the mobility.
Yes, mobility. Which will be more mobile?
Detachment is more mobile.
Okay, and
Maybe pigmentations and
what did you say? No,
pigmentations, the demarcation line,
okay, demarcation line will be seen in what?
detachment also.
Okay.
And the location, maybe it's more common in this location in the retinoschisis.
Okay. And now, how do you clinically say that this is retinoschisis or retinal detachment?
The history first, the patient will, if detachment, he'll feel like a curtain, like a drop of vision, sudden.
If it is peripheral, it will not be, if it is peripheral, how
Yeah,
will cause vision
Yeah,
loss.
but the patient came to complain or suddenly
No, it is an
discovered.
incidental finding. So,
Mm.
so Dr. Mala, you will read about how to differentiate retinoschisis
Okay.
from
Yeah,
retinal
retinoschisis.
cavity.
Okay.
And
Okay.
what are the types of retinoschisis?
What is what?
What are the types of retinoschisis you know of? Like, what are the clinical types of retinoschisis? If it is seen 3 year old, then what is the name of this retinoschisis?
I don't remember so far, but there is the X-link type and there is right?
Yes. So there is X-linked retinoschisis, which is seen in young male or male child, and this degenerative retinoschisis. This is called degenerative, and you will also read about differences between degenerative retinoschisis and X-linked retinoschisis.
Yeah, and the difference in the
excuse me.
splitting layers is different from the adult, from
Yes,
the child.
yes. Layers of splittings are different, and also that is genetic, and this is not genetic. This is a degenerative thing, and also you will read about the predisposing lesions, retinal lesions, which cause degenerative retinoschisis.
Okay.
I think you did good, but definitely this is a rare scenario, but yes, it can be given. They can show you OCTs or ultrasound, and how do you differentiate in ultrasound also? It is you need to know.
Sir, once
Who
again, how to
In the
describe the lesion?
in the OCT, we will find the splitting. It will differentiate the splitting between the RD and the retinoschisis. In the retinoschisis, we will see in the mid layers after the neurosensory retina.
Yes,
Correct?
within the there will be splitting within the neurosensory retina. In RD, it will be separate. The neurosensory retina will be separated from the RP.
But we cannot say other differentials like choroidal detachment or choroidal mass or
Yes, because this image is not very prominent. You can say choroidal mass will be a TD or choroidal detachment will be a TD, because this is not clear. If they gave you the photo like OCT or ultrasound of this along with this photo, then you can be more sure.
Okay. Thank you.
Yes. So who will volunteer next? Dr. Caroline? Look, I am again saying again and again, this is just a mock. This is nothing. Like, nobody is judging you. This is just to see how prepared you are, and you need to know your weaknesses. Otherwise, you cannot improve on that. So, who will volunteer next?
I will volunteer, sir.
Doctor?
Reshma.
Yes, Doctor, please introduce yourself, Dr. Resma.
I'm Dr. Reshma. I'm from Kerala. I'm a general ophthalmologist.
Okay.
Sir, this looks like a peripheral. It is a color fundus photograph showing the periphery of the retina. Looks like a superior aspect of a retina, which I cannot identify. It shows a peripheral horseshoe retinal tear superiorly, and there is a corrugated, minimally opaque retina, suggestive of a phlegmatogenous retinal detachment.
Okay, so this patient has vision loss, and how do you manage this case?
So, if this, since the patient is having vision loss, then it might be involving the macula also. So, it is an emergency, and the patient has to be evaluated. Since how much of vision loss at presentation has to be checked, and RAPD has to be checked, and dilated fundus examination of both eyes should be done. If at all, then whether and the other eye also, there should be. Hello. Ruled out for any retinal break or tests. Yes, sir.
Okay, if there is no retinal break, but there is lattice.
Then in this patient, since the vision is involved, then the management is an emergency pass plan.
In the other eye, if you see that there is a lattice, no break,
It should be lasered, sir. It should be prophylactically lasered because this is a vision loss and a phlegmatogenous RD in this eye. The other eye has to be prophylactically lasered. Barrage laser has to be given.
what is the percentage if a person has retinal detachment is one eye? What is the chance that other eye will also have retinal detachment?
Exact percentage, I don't know, sir.
Okay, just read about this. And how would you manage this case in this eye? This is a
It
pseudopathic
should be
patient. How do
a pars, it should be a pars plana vitrectomy with a laser, endo laser, and then removing subretinal fluid through the brick, and after that endo laser, and then perfluorocarbon applied and flattened the retina, and a tamponating agent, either a silicon oil or a C3F8 or a SF6 is applied, and that is the treatment for. And
Okay, very good. If the patient is given C3F8 intravitreally, so what are the precautions he or she should take?
then there should be he should avoid air travel, and
Why?
because it can expand, because these are expandable gases.
So do you inject expansile gas or isoexpansile?
Isoexpansile, we put it at SF6 as a 20% and C3F8 15% is being applied, because it should be isoexpansile.
C3F8 tell 12 to 14%, not 15%. Okay, it is better to give a 12 to 14% is the A. And though it is isoexpansile, but in lower like if the environmental pressure is low, then it can expand and it can cause high IOP and can cause glaucoma. And what happens to the vision after if you put gas? What happens to the vision in the first few days?
For initial days, the visual acuity will be low, and as the
Then
air
it,
or the gas gets absorbed, then only the visual acuity normalizes or equals the previous vision.
okay. I think we'll I have collected few more images. I'll just discuss, and any one of you can like volunteer and tell what is seen. So what is this and what
Sir,
is seen?
sir, one question,
Amsler
please.
grade.
Which gas preferred now, like if the examiner asked it?
So no, it will depend on the uh, surgeon's preference. So in retinal detachment, most of the surgeons prefer like a long-acting gas C3F8, but you can put SF6 also. So this is like majorly surgeon's prefer. And oil can be given in cases which have inferior breaks and the patients who cannot maintain positioning. So in those cases, you'll have to prefer oil. Also, there are in giant retinal tear or in patients with PVR, proliferative vitreous retinopathy, or young patients in whom retinal you expect that recurrent retinal detachment can happen. So in such cases, silicone oil is more preferred. So
And if the
basically,
patient is one-eyed, if
yes,
the
yes,
patient is one-eyed, gas is preferred or silicone?
silicone oil, because if you put gas, then he will be not able to see for a long time. So it will depend on the like gas. So for SF6 it will may take up to 1 month, and for C3F8 it may take up to 6 weeks to 2 months. So that's why in your one night patient you will try to give put silicone oil so that they are mobile after surgery, or they can like do their own work. So what is this and what is this showing? Any can basically this will be rapid fire. Anyone can tell, and we'll go to the next. Just
Amsler
chart showing
metamorphosis. Amsler. Read about the types of Amsler chart. How many degrees does it cover, and in which situations it can be used. So what is this?
these are
Drusen,
Rutens,
soft drusen, some
Yes. So
contrast also.
how
hard
do you
and soft.
define small, large, and intermediate erosion? How is it defined?
Less than 63, 64 to 125, and more than 125.
How do you know that 63 or something?
Uh,
How do you
we look at the vein at the disc margin and compare it with that.
what is the thickness of that?
That is 125.
125
Okay.
micron.
So if this patient is this patient has choroidal neovascular membrane in the other eye, and this eye has this. So what would you advise for this eye?
There is RPE mottling here, so the risk is high. So I can advise for antioxidant and ampler grid, regular OCT, and regular follow-up.
Yes. So basically, you do OCT and advise them to stop smoking. That is very important if they are smoking or taking tobacco products, and arrest formulation is indicated in such a cases. Arrest we need to read. So what is this image? So
Serpiginous choroidopathy.
So no,
Chorioretinal atrophy.
due to
Myopic.
yes, this is pathological myopia. Look, serpiginous choroiditis we doesn't look like this. This is like total choroidal atrophy, and you are seeing sclera. So this is typical feature of myopic eye. Then the question may be, what are the common causes of vision loss in myopia? It can go to retinal detachment, myopic choroidal neovascular membrane, or posterior staphyloma also. So what is this?
What could be the other causes that can make similar to this photo, like chorioretinal atrophy, other than dystrophies and myopia?
Other than, so this is mostly, this will be due to pathological myopia. Other than dystrophy can also cause, but this image, the appearance of disc and the choroidal scar, this is like
Iridemia, so then it will be more uniformly spread, not
yes,
uniform.
yes, and guided atrophy will be peripheral. It will be not the
Peripheral,
center.
yes.
So A will be in the periphery first. Periphery, mid periphery or periphery first, there will be scalloped areas. So this is like choroidal atrophy, which is involving the posterior pole majorly around the disc, and also involving around the fovea, and the disc also looks myopic. So this is pathological myopia only.
Thank you, sir.
So what is this?
Atypical
Eight track appearance.
Congenital hypertrophy of RP.
Typical grouped CHRP.
Group CHRP. Okay, this is also called BR tract pigmentation. So this might not be associated with this thing, familial polyposis coli. So these are mostly benign, but you need to know how like atypical CHRP may appear, and the like how you should evaluate such cases. So read about CHRP, group CHRP, typical CHRP, atypical CHRP, and solitary CHRP. So what is this?
Choroidal melanoma.
Choroidal melanoma. Yes, read about ultrasonic features, histopathological features. What are the, how do you know that choroidal nevus has more chances of becoming choroidal melanoma? There is this thing, there is this mnemonic, like to find small ocular melanoma doing imaging. Just read about it, and you need to know these things. These are important, and how the management also you should know. So what is visible here?
Bottom fat TB.
Yes, you need to know about the reason, like causes of granulomatous uveitis, and how you should investigate granulomatous uveitis. So this is a like child.
Retinoblastoma.
How like ultrasonic features, your management options, grading of like staging of retinoblastoma, and newer management options. So what is this?
Astrocytic
Astrocytoma.
Astrocytic hamartoma. So what is the system association now?
Neurofibromatosis, tuberculosis, sclerosis, sometimes retinitis pigmentosa.
Yes. So the primary association will be tuberous sclerosis, not
Tuberous
neurofibromatosis.
sclerosis.
Yes. Then you say neurofibromatosis, or even yes, A also can also retinitis pigmentosa can also. Read about the types of this thing. What are the ocular imaging features, ultrasonic features, and what are the complications associated with it. So what is this?
Macular.
What drug can this patient is taking a drug? What drug could it be?
Hydroxychloroquine.
Yes, hydroxychloroquine related toxicity. There you need to know the other like association causes of bullseye maculopathy, how their angiographic features, their OCT features. So
Here's
what
the
is this?
photo looks like macular hole.
What? No.
Um,
This yes, macular hole will also be a DD. But look at this. The macular hole, the redness of the fovea should be much more. So
okay.
this is primarily a bullseye maculopathy, but if you are not sure and if the image is blurred, you can see that yes, macular hole can also be DD. You will have to do optical coherence tomography of macula to know what is happening. So what is this? Angioid streak, and there is some subretinal hemorrhage there, and you need to know what are the causes of associations of angioid streaks, what are the complications of angioid streaks, and read about pseudoxanthoma elasticum. So what is this? This is hyperautofluorescent material, which yes,
Chronic CSR.
yes, chronic CSR can also be a DD. Any other DD, if it is highly hyperfluorescent, if this yellow or orange things are highly
Amelanotic choroidal melanoma.
that can also be a differential. But if it is similar in both eyes and with high autofluorescence, hyperautofluorescence,
Stargardt, best disease.
Best.
ideal form dystrophy should be ruled out in such a case. All other like CSCR and multiple myeloma can also be a DD. So what is this? Bilateral symmetrical findings in a young, like 20-year-old woman. Target, not toxoplasma. Toxoplasma will be much more pigmented. So this is like foveal atrophy or like greenish type lesion in the fovea, which choroidal vessels are more. Yes. No, not telangiectasia here. There is a foveal atrophy with choroidal vessels visible, and there are pisiform plaques.
Here, why it is looks greenish. It looks greenish, like not atrophy, like not whitish, yellowish.
No, it is not white. It is like greenish, and because choroidal vessels are more prominent in the center. So this is a foveal atrophy, area of macular atrophy, which is surrounded by pisiform plaques, which is typically seen in Stargardt disease. What is this?
Chemistry? No. This retinitis pigmentosa.
Retinitis pigmentosa. So there are pigmentary, like there are RP mottling here, and disc appears a little pale. Arterial attenuation is there, and also there are pigments, bony specular pigments, which are there. You need to tell that I want to see the periphery and the other eye. Also, always say I want to see the other eye. What is this?
Tremia?
Choroideremia.
Choroidal, and it should be ruled out in such a case. What is this? Young patient with central scotoma.
Jana.
CSCR.
You need to rule out CSCR here, and that there will be like what are the like angiographic features, etc. So, what is this? ROP, read about stages of ROP, the areas like zones of ROP and management of ROP, or also read about the newer classification. What is this? A patient with sudden onset.
Cherry red
Yes.
spot macula.
CRA. So this you need to understand. There is a sudden onset vision loss in one eye. There is RAPT and there is severe vision loss. So what is this?
Infratemporal BRVO.
Here. Yes, and there will be multiple like causes, management, etc. What is this sudden onset vision loss?
Could be toxoplasmosis.
No. Like yes, toxoplasmosis can also be a like TD, but they are mainly the vision. Look, it can be vitreous hemorrhage, it can be vitritis. But in vitreous hemorrhage, the hue is more red. In vitritis, it is more of whitish or like just haze. So this is majorly reddish hue, reddish glow. So that is, and also you can see some hemorrhages in the retina also. So this is retinal vitreous hemorrhage. So what is this?
PRP.
Post is mostly diabetic retinopathy. So what is this?
Rosy spots.
Causes of rosy spots you need
It
to
could be
read.
leukemia. It could be infective endocarditis.
Yes, leukemia, anemia, subacute bacterial endocarditis, etc. What is this? Bilateral similar.
Fractional RD not involving the macula.
Proliferative diabetic retinopathy.
Yes, proliferative diabetic retinopathy with TRD. So these are the things, and I think Dr. Aya had sent a message on the possible clinical scenario which can be asked. So please read about those, and also most important is practice. You have to practice examination and try to uh, get few people who can read together. So if you do that, you can do better. And also, please examine if you are not practicing retina, it is okay, but you need to examine the patients with 90D and indirect yourself, and you have to formulate the plan, and then you can go to the retina specialist and discuss with them if your plan was correct or not. If you do not examine your patient yourself, then it is very difficult. And also do oculoplasty yourself, squint exam yourself. So I think I'll conclude if there are any
Sir,
questions.
I have two questions.
Yes.
Multiple times they ask about genetic counseling in RP and retinoblastoma. So
Yes.
when they ask how to, reply to this question regarding genetic counseling in both these conditions.
In genetic counseling, you say that, sir, I'll examine the patient. I'll ask them to bring the family members here, and I'll try to make a pedigree chart of this, and I'll try to identify what is the inheritance pattern here. So if and the prognosis depends on the inheritance pattern. You will read about how it affects inheritance patterns affect the prognosis, and then if they are willing, we can do genomic sequencing and know the gene which is there, and if I can know the gene, we can formulate the prognosis of the disease. So that is if then they can ask like what are the major autosomal dominant gene which are involved, what are the major X-linked genes which are involved, and what are the major autosomal recessive genes which are involved. So that finishes. So whenever there and in retinoblastoma, you need to remember the percentages which are there. Like if there is bilateral disease, and a mother and father are involved, or then you have around 40% chance of the in the both the sibling and also offspring. So this is important. So just remember the percentages. There is a good book by Dr. Santosh Munawar. You can, and it is very simply written there.
Right,
So,
Dr. Santosh.
Munawar.
Munawar. Okay.
Yes, search retinoblastoma by Dr. Santosh Munawar. You will get that, and just remember. And I have already posted PDF with common genes, like in X-linked retinocyte, X-linked RP, this is RPGR majorly.
Right. Okay, sir. Thank you. And in RP also the same answer, right? Basics the same.
Yes, in any genetic counseling, you say how you will clinically approach. You say, sir, I'll examine the patient, and also I'll try to examine all the family members, blood relatives who are there, and then I'll try to make a pedigree of that. If they're not available, I'll try to ask about like whether they had night blindness or not. And after you make a pedigree, you are sure you can like know how is it transmitted. So if you know that, then you can tell them like the usual prognosis about that. And if the patient is more willing, then we can go for the genetic blood testing, which will tell us more about the prognosis and how the future generation can be affected, or what prognosis can be expected in them.
Right. Thank you so much.
Try to be clinically oriented so that the examiners know, yes, you have thought about it. And I think we'll conclude now. Thank you. And there were multiple, because we have these are old photos, and I'll thank everyone, and I pray for you, pray for your success, and try to practice gratitude. If you have had any benefit from this class or any other class from our our activities, or any other person for the matter of fact, try to express gratitude, because it is the sweetest source of inner peace and pure happiness. So if you want to be happy, you need to appreciate others who are doing and
Yes,
trying to help them.
absolutely.
Thank you, sir.
Thank you so much.
Good day.
Thank you.
Thank you, sir.
Thank you, sir. Thank you so much.